Director at the Center for Sickle Cell Disease, and I give it to you.
Oh, thank you, Barbara. So just a couple of notes on that. The first director of the Center for Sickle Cell Disease was Roland Scott, who in 1972 was the force behind getting the National Sickle Cell Control Act passed. Prior to 1972, there was no research on sickle cell, and it took a public law to tell people to do that. So I'm tremendously honored to fill Dr. Scott's shoes. I have very small feet. He has big shoes to fill, but it's a pleasure to be here. So I'm going to be talking about treatment for sickle cell disease and really echo some of the things that Barbara has already talked about. I'm going to talk about polymerization, clogging of the blood cells or vasoocclusion, hemolysis or decreased red cell survival, and inflammation in sickle cell disease. Next slide, please. So Barbara already mentioned this. When there's no oxygen around, sickle hemoglobin polymerizes and makes these long, sharp strands with the red cell, and it takes on the sickle shape. They're rigid and they clog up the blood vessels. Next slide, please. These are pictures of sickle cells under the microscope. They're pretty easy to identify. Next slide, please. So what are the things that can interfere with polymerization? Well, baby hemoglobin does. This is called fetal hemoglobin. You live longer if you have higher levels, and you have fewer painful crises. Next slide, please. Excuse me. Next problem is clogging of the blood vessels. Next slide, please. This is just a picture of those rigid sickle cells clogging up blood vessels. So these rigid sickled cells clog up very, very small blood vessels that you normally red cells have to squeeze through. And the consequence is they don't get oxygen to the tissues, and that hurts and that causes pain. Next slide, please. Next problem is called hemolysis or red cell survival. Next slide, please. So these rigid sickle cells, when they form, they blow up or they don't survive very long. And they've got a lot of stuff in them, including hemoglobin and a bunch of enzymes. And when they explode in the bloodstream, it causes a whole bunch of problems in your blood vessels. Next slide, please. And so normal red cells last 120 days. In sickle cell disease, the red cells survive perhaps 14 days, a dramatic reduction in red cell survival, and that results in tremendous anemia. Next slide, please. Excuse me, a long time ago, I divided people into two different groups in sickle cell. Those with red cells that survived a short period of time and those with red cells that survived longer. Those with red cells that survived longer had more sickle cell pain and were in the hospital all the time. And the people who had very short surviving red cells and more anemia, they didn't get much pain at all. In fact, they weren't really in the hospital, but they had tremendous other problems. Heart and lung problems, leg ulcers, kidney problems, strokes, things that usually, if you don't, wouldn't come to attention. Next slide, please. And then last thing is inflammation. Next slide, please. So what is inflammation? This is my analogy as when you get a flu shot, your arm hurts the next day. That is white cells or the inflammatory component or inflammation in the muscle of your arm, and that's why it hurts. Dying red cells attract white blood cells, and that hurts. So you get lack of oxygen, clogged up blood vessels, exploding red cells, then white cells coming there, and all of that combined together hurts. And this may cause actually tissue injury when you have those white cells in that site. Next slide, please. Okay, what can we do for sickle cell disease? Barbara mentioned newborn screening. First newborn screening study done by Dr. Scott in 1948 at Freedman's Hospital right across the street from where I am now. First study in the United States, and Dr. Scott really transformed medicine. That was the first example of using newborn screening. Why do we do it? Because we can make changes early in life that save lives, okay? So little kids, when they're identified with sickle cell disease, we put them on penicillin, we vaccinate them. Okay, so what are the therapies for sickle cell disease? We have 4 drugs, transfusions, and experiments. Next slide, please. Longest standing drug, this was approved in 1995, is hydroxyurea. Basically, it turns on that baby hemoglobin and makes it go higher. Next slide, please. It inhibits the sickling reaction. And what does it do? It decreases your pain crises by 50%, fewer pneumonias, you live longer, and you need fewer blood transfusions. Next slide, please. L-glutamine, approved in 2017. So 1972 to 1995, that was the first drug. 1972 to 2017, that was the second drug. L-glutamine, so what is it? It's an amino acid, a dietary supplement, if you will, but it makes an antioxidant. Next slide, please. What are antioxidants? Next slide. Yeah, there we go. So NAD, last slide. NAD is the antioxidant in the red cell. The red cell is full of iron, water, and oxygen. You put those 3 things together, it's the planet Mars. There's oxidized iron all over and it turns red. And that's why our red cells are red. But when you have too much oxygen, the iron is not in the 2+ state, it goes to 3+ and it destroys everything. It's basically rust in the red cell. It's like your car rusting, it falls apart. And that's why the red cells die. So the benefit of L-glutamine is it makes your red cells survive longer. Next slide, please. And surprisingly, it also decreases pain crises. Not a lot, but about by 25%. It's only available for SS sickle cell. Next slide. 2019, November, 2 drugs approved, delayed release really because of the pandemic. The first is a monoclonal antibody. Well, what does that do? This is something that targets those inflammatory white cells and keeps them away from sickled cells. It's called Crinzalizimab. You come in once a month, we give you an IV infusion. It was approved off of a phase 2 clinical trial, and I'll get to that at the end. Next slide, please. It decreases pain crises by about 40%. And this was a trial, patients were already on hydroxyurea, and it actually doesn't matter what type of sickle cell you have. You can have SS, SC, S-beta thalassemia. So prior to 2019, if you had SC or S-beta plus thalassemia, that's about 20% of patients, no drugs available for you. First drug that we have. Next slide, please. Next drug, November 2019, Voxelator, small molecule. It binds to the hemoglobin molecule and it makes oxygen stay on hemoglobin. So you get no sickle polymer formation. You have nice round red cells. It results in higher hemoglobin. So we use this primarily in people with low hemoglobin. Next slide, please. But it has no effect on pain. Surprising, because this really alters sickle cell in a way that we would expect on paper to fix everything. And this is why we have to do clinical trials to figure this out. We get all sorts of surprises. Next slide, please. Transfusions. I don't like them in the hospital for a lot of reasons. But if we put you on them once a month, we can dramatically reduce your pain crises. If you've had a stroke, we can prevent future strokes in most cases. And if you have those heart and lung problems like congestive heart failure, again, transfusion therapy once a month can really help. If you're going to get surgery, you have to get transfused. Next slide, please. Okay, experimental stuff, stem cell transplant. This is where you're a match to your brother or your sister. Those are the only good matches. You have to get the same 2 copies of chromosome 6 from your parents as your brother or sister, and they can be a donor, okay? There are several different versions of this, but one that's really important is where we don't wipe out the bone marrow. Because when we wipe out the bone marrow, there's about a 10% chance that you will die from complications of immunosuppression or an infection or the stem cells not engrafting in your bone marrow. If we don't completely wipe out your bone marrow, some of your cells come back and the donor cells and they mix together. We call you a mixed chimera. And that actually means if you don't engraft or something bad happens, your sickle cell comes back. And that's not a good thing, but you're still alive. So next slide. This is highly experimental. The one thing that I'll point out, in the United States, about 118 people have had bone marrow transplants. For thalassemia, so there are 100,000 sickle cell patients in the US. There are about 2,000 beta thalassemia major patients in the US. About 100 of them have had bone marrow transplants. So we do it more frequently for other diseases than we do for sickle cell. It's a disparity. I don't like it. Next slide, please. Gene therapy. So this is where we take a virus and we put a normal hemoglobin gene in the virus and we put it in your stem cells in the laboratory, and then we infuse those stem cells into your bone marrow, but we wipe out your bone marrow. Okay? Next slide, please. So these gene therapy trials started in 2017. Earlier this year, in 2021, February, one of the gene therapy trials was halted because the first 2 research subjects died from leukemia that was due to the chemotherapy that was given. So these are not easy decisions to make, whether to do a bone marrow transplant or gene therapy, but recognize that these are experiments, and that's why the trial was halted, okay? Because we have to figure out why it happened, and we have to protect people, because this is an experiment. Next slide, please. There's a new method called gene editing with something called CRISPR-Cas9. So we can go in and either break up a gene that turns off fetal hemoglobin, or we can figure out how to fix the sickle mutation. That's the big picture. So we take your stem cells out, we edit them in the laboratory, and then transplant them back into you. Next slide, please. So this is just a picture of it. CRISPR-Cas9, that's what happens in the nucleus of your cell, your stem cells. Next slide, please. And this is from December of 2020. This is the first 6 patients who've gotten a gene editing experiment that turns off a gene that turns off fetal hemoglobin. What I want you to understand is they did 6 patients, and this is called a proof of principle, first in humans. 6 people, most of them were on transfusions, and pre-study had no vaso-occlusive events except for 1 person. The 1 person who had vaso-occlusion continued to have hospitalizations for pain afterwards. So while I'm excited that 6 patients got it, we're not there yet, and we haven't cured it. This is not durable, okay? Next slide, please. Quality care metrics. I just wanted to go through a few things. So one thing, as Barbara mentioned, sickle cell disease is really a disease of people of African descent, and they are mostly distributed starting in the mid-Atlantic and into the deep south. A few other places, but that is all this dark blue area. Georgia, South Carolina, Virginia, Maryland have a lot, and Washington, D.C. has a lot too. Okay? Couple of other things. Patients between 46 and 75, only 8% of sickle cell patients are over 46 years of age with Medicaid. So this is government data. Next thing I want to highlight is kids who get screened for stroke risk. Only 37% of children with sickle cell disease get this important test done. Pneumococcal vaccinations, only about 2/3 get vaccinated. That's one of the really important things to do in sickle cell. And then the last is in the middle, hydroxyurea on the bottom is adults with sickle cell disease. Only 10% of adults with sickle cell get a year's worth of hydroxyurea during the year. 90% don't get it all the time. Next slide, please. This just shows that sickle cell patients, they're on the left, they're in the ERs a lot, they're hospitalized a lot compared to any other patient population. This patient population has the highest readmission rate in 30 days to a hospital. Next slide, please. All right, treatment disparity and cost. What I wanted to show you about this, only 16% of adults in Washington, D.C. in 2017 were on hydroxyurea. I was the #1 prescriber, and that's why Medicaid called me downtown to ask about these questions. There are about 600 adults in the district who have DC Medicaid. and they spend $71 million a year on these 600 people. That's about $120,000 per patient. Most of that cost is in the ER and the hospital, where they're not making you better. Next slide, please. So this translates nationally into a huge cost of billions and billions of dollars. Next slide, please, for a disease that is very rare. This just shows, last slide shows funding for sickle cell disease, cystic fibrosis, and hemophilia. There are 100,000 people with sickle cell disease, 30,000 with cystic fibrosis, and about 20,000 with hemophilia. All are genetic diseases with onset in childhood. But you can see for sickle cell disease, it has the lowest funding in research dollars per affected patient of any disease. And if you go to the next slide, what does that mean? That's why we have fewer drugs. There are 36 as of 2019 for hemophilia, 2 at the time for sickle cell disease, 8 for cystic fibrosis, and 39 for HIV. These are research publications for sickle cell disease. It's in red, and you can see fewer publications because there's less money and less research being done on this important disease. Next slide, please. Okay, how do we protect participants in clinical trials? Next slide. There are lots of different studies, and they can be low risk to high risk. So I used to run a cohort study of about a 1% sample of adults with sickle cell disease in the US. Low risk. Okay, there are patient sample studies where we just need your cells. Low risk. Bigger risk is if we ask you for your DNA, you're giving us your fingerprint. It's like your social security number. And then there are experimental drug studies, and the highest risk are the curative therapies, as I've alluded to, with bone marrow transplant and gene editing and gene therapy. Very important trials, but you really need to discuss risk very, very carefully. Next slide, please. So how do we really protect yourself? Well, there are different types of drug studies. Phase 1 trials are first in humans. All we're trying to define is the dose and the safety. We don't look at anything else. So if you're on a phase 1 drug study and you see me, I'm going to tell you that very, very bluntly. It's high risk, it's safe, but unexpected results can happen. Phase 2 trial, we get into hundreds of patients. We test the final dose and we suggest a benefit based upon the data. The Voxelator and Crinzalizimab were approved off of phase 2 studies because sickle cell is such a rare disease and there's no therapy for them. Next slide, please. The final level of testing, and we've heard a lot about this year with the COVID vaccines, went through phase 3 clinical trials. Pfizer's vaccine trial had 44,000 people on the trial, half getting the real vaccine, half getting a fake. And that's what a randomized trial is. You're blinded from it, so your doctor doesn't know what you're getting, you don't know what you're getting. At the end of the trial, we broke the code and we asked the question, is there benefit? What is the goal of a phase 3 trial? It's getting FDA approval. And the FDA will not approve a drug or a vaccine unless it really has benefit. Why do we do this? Because in the 1800s, we were selling snake oil, which is mostly alcohol, to people, saying, my snake oil will help you, and it didn't. So that's how the FDA came about. Next slide, please. How do we really protect you in this? We have an ethics review board. This is called an IRB, or an institutional review board. Their goal is to protect patients from investigators' bias. So think about the Nazis in Germany doing experiments on people in concentration camps. Those were prisoners. That is not ethical then or now. That was a gross misappropriation of research, and that's how IRBs came about, to protect patients from people who lose their perspective and do bad things. Okay, if it's a drug study, we have a data safety monitoring board, or a DSMB, because we stop studies early if there's harm. I was involved in one study 10 years ago that we stopped early because it caused vaso-occlusive pain. Or if there's clear benefit, the hydroxyurea study was stopped early because we saw that it was beneficial and we offered it to everyone. Next slide, please. All right, how do we really, so then the question is, how do we really protect patients when the care standards are so low in sickle cell? People are hospitalized, only 10% are getting any of the drugs that are available. So my experience is also with some of the transplant and gene therapy patients. Howard University has 7% of the people who have received stem cell transplants in the United States. We do not have a stem cell transplant program. So these are people who all didn't do well with the transplants. Essentially, they didn't work, and they come back to us. They're not with the people who gave them the transplant. And that disturbs me to an extent, because we just want to make you all better, but we want to protect you from these negative consequences and really scrutinize them.